Hey everyone, Chris here from MedPrep2Go, and I wanted to let you know about our premium Step 2 Bundle podcast, which gets you all of the Step 2 secrets and our Step 2 questions podcast combined and ad-free. You'll also get early access to all of our Step 2 questions episodes before they're released public. The bundled podcast is available now, and you can save over 40% with an annual plan. Details at medprep2go.com. Do you need a break from studying? Check out the Dr. Raj podcast, where he discusses topics such as wine with Jesse Katz, sarcoidosis with Bob Saget, saving the bees with Sydney S. Sill, and so much more. The podcast also features guest host Becca Spar, who focuses on leadership and connection, as well as Dr. Michelle Kulai and her Everyday Rooms segment, where she talks to patients to share their stories and the challenges that come with different conditions. Just search for the Dr. Raj podcast wherever you're listening now and tune in for a variety of great guests and topics. Hey everyone, Chris here from MedPrep2Go, and I wanted to ask you to please follow us on social. There may be links in the show notes, or you can find us at MedPrep2Go on Facebook, Instagram, LinkedIn, and now YouTube. We would greatly appreciate it as we try to spread the word about MedPrep2Go and keep medical education accessible and affordable. Hey everyone, Chris here from MedPrep2Go, and welcome to our USMLE Step 1 Questions podcast. In this episode, I will be reading 3 pathology questions from our online qbank, and just a quick reminder that you can read these and other great questions on our website at medprep2go.com. So with that being said, let's get started with question 1, Pathology 40. A 4-year-old boy presents to the pediatrician with his parents for evaluation of increasing irritability, dysuria, and trouble urinating for the past 2 weeks. Past medical history is significant for vesicoureteral reflux and 4 complicated urinary tract infections in the last 2 years, which were treated with the appropriate antibiotics. Social history and family history is unremarkable. He does not currently take any medications. The patient's mother reports that he has felt hot the last few days. Vital signs show a temperature of 38.9 degrees Celsius, 102 degrees Fahrenheit. Blood pressure is 108/72 millimeters of mercury. Pulse 112 beats per minute, and respirations 18 per minute. Height and weight are appropriate for age. Physical examination reveals costovertebral angle tenderness to palpation. The patient is started on a standard course of antibiotics. Following completion of the antibiotics, a thorough evaluation leads to a kidney biopsy, which reveals tubular atrophy and loss of overall architecture. Which of the following is the most likely diagnosis and gross pathology? Is it A, acute pyelonephritis with enlarged kidneys and loss of corticomedullary junction, B, chronic pyelonephritis and shrunken scarred kidneys, C, renal cell carcinoma and fatty laden mass in the upper pole, D, Wilms tumor and large mass in the kidney parenchyma, or E, xanthogranulomatous polynephritis with enlarged kidneys and abnormal renal outline. And the correct answer is B, chronic pyelonephritis and shrunken scarred kidneys. This patient is presenting with signs and symptoms of pyelonephritis. This, combined with the past medical history of vesicoureteral reflux and complicated urinary tract infections, suggest a progression to chronic pyelonephritis. The kidney biopsy findings solidify a diagnosis of chronic pyelonephritis. Tubular atrophy and loss of architecture demonstrate the effects of repeated immune responses. On microscopic exam, one might also expect to see thyroidization of the kidney. Grossly, the kidney will appear small and scarred. Answer choice A, acute pyelonephritis with enlarged kidneys and loss of corticomedullary junction, is incorrect. Acute pyelonephritis would present with cellular infiltration. Chronic pyelonephritis does not present this way. Answer choice C, renal cell carcinoma with fatty laden mass in the upper pole, is incorrect. Renal cell carcinoma is uncommon in children. Additionally, the biopsy would reveal cells with clear cytoplasm arranged in nests, clear cell carcinoma. Answer choice D, Wilms tumor in large mass in the kidney parenchyma, is incorrect. Wilms tumor, or nephroblastoma, is a common pediatric tumor. However, the renal biopsy would reveal triphasic histology, blastema, epithelial, and stromal. Additionally, the patient's clinical presentation is not typically how nephroblastoma presents. Answer choice E, xanthogranulomatous polynephritis with enlarged kidneys and abnormal renal outline, is incorrect. Xanthogranulomatous pyelonephritis is an aggressive form of chronic pyelonephritis. One would expect to see granulomas on histology. Key learning point. A pediatric patient with a known congenital ureteral disorder and recurrent complicated bouts of pyelonephritis can lead to chronic pyelonephritis. This is characterized by gross, shrunken, and scarred kidneys and microscopic tubular atrophy with blunting of the renal calyces. Question 2, Pathology 41. A 67-year-old male presents to the emergency department with a productive cough and dyspnea that started 1 week ago. He has a past medical history of hypertension that is appropriately managed with chlorthalidone. Social history and family history are unremarkable. Vital signs show temperature of 38.9 degrees Celsius, 102 degrees Fahrenheit, blood pressure of 128/82 millimeters of mercury, pulse 93 beats per minute, and respirations 22 per minute. The patient is 71 inches and weighs 198 pounds. Physical examination reveals mild tachypnea and rhonchi at the left lung base. Chest X-ray reveals a left lower lobe consolidation. Based on the patient's clinical picture, which of the following cells is most likely to be damaged? A. Club cells, B. Dust cells, C. Goblet cells, D. Type 1 pneumocytes, or E. Type 2 pneumocytes. And the correct answer is D. Type 1 pneumocytes. Type 1 pneumocytes are thin squamous cells that are chiefly responsible for gas exchange. They comprise 95% of the alveolar area. In the presence of pneumonia, fever, productive cough, dyspnea, and consolidation on imaging, resulting injury leads to damage of this thin squamous cell. Damage to the cell responsible for gas exchange impairs normal physiological respiratory function. This results in a decreased ventilation/perfusion VQ ratio and a compensatory increase in respiratory rate as seen in this patient to offset this loss of function. Answer choice A, club cells, is incorrect. Club cells are responsible for maintaining epithelium in the respiratory bronchioles. These cells are not especially susceptible to injury. Answer choice B, dust cells, is incorrect. Dust cells are macrophages within alveoli and alveolar ducts. They are responsible for clearing foreign debris from the alveolar space and are not the cell type that is most likely to be damaged in the presence of infection. Answer choice C, goblet cells, is incorrect. Goblet cells are found in the trachea and bronchi. They are mucus-producing cells. These cells are not susceptible to damage in the presence of pneumonia. Answer choice E, type 2 pneumocytes, is incorrect. Type 2 pneumocytes are responsible for surfactant production in the alveoli. Following injury to the alveoli, type 2 pneumocytes are responsible for regeneration of type 1 pneumocytes. Key learning point. A pathological process that causes alveolar lung injury is most likely to result in type 1 pneumocyte injury. Type 1 pneumocytes are responsible for gas exchange and are most commonly damaged as a result of lung injuries. Type 2 pneumocytes can trigger the regeneration and proliferation of type 1 pneumocytes following injury. Hey everyone, Chris here from MedPrep2Go, and I wanted to let you know about our premium Step 1 Bundle podcast, which gets you all of Crush Step 1 and our Step 1 Question podcast combined and ad-free. You'll also get early access to new content as it becomes available. Upgrade your studying now and learn more at medprep2go.com. Question 3, Pathology 42. A 22-year-old man comes to the clinic with a history of intermittent jaundice, which he has noticed particularly during periods of stress, fasting, or after minor illness. He has no significant past medical history and denies alcohol or drug use. He is not on any current medication. Vital signs are temperature 37.1 degrees Celsius, 98.6 degrees Fahrenheit, blood pressure of 118/72 millimeters of mercury, pulse 70 beats per minute, and respirations 18 per minute. His physical examination is unremarkable except for mild scleral icterus. Laboratory tests reveal a total bilirubin level of 3 milligrams per deciliter with an indirect, unconjugated bilirubin of 2.8 milligrams per deciliter and direct, conjugated bilirubin of 0.2 milligrams per deciliter. Liver function tests, hemoglobin, and reticulocyte count are within normal limits. Which of the following is the most likely diagnosis? Is it A. Crigler-Najjar syndrome, B. Dubin-Johnson syndrome, C. Gilbert syndrome, D. Hemolytic anemia, or E. Rotor syndrome? And the correct answer is C. Gilbert syndrome. This patient's presentation of intermittent jaundice, particularly during stress, fasting, or illness, along with an isolated increase in unconjugated bilirubin, is characteristic of Gilbert syndrome. Gilbert syndrome is caused by a reduced activity of the enzyme UDP glyconeurosol transferase, which is involved in the conjugation of bilirubin. Answer choice A, Crigler-Najjar syndrome, is incorrect. Crigler-Najjar syndrome presents with severe jaundice and kernicterus in infancy due to a complete absence of UDP glucuronosol transferase. Answer choice B, Dubin-Johnson syndrome, is incorrect. Dubin-Johnson syndrome is characterized by conjugated hyperbilirubinemia and a darkly pigmented liver. Answer choice D, hemolytic anemia, is incorrect. Hemolytic anemia would present with signs of hemolysis such as increased reticulocyte count, low haptoglobin, and elevated lactate dehydrogenase (LDH). This patient has normal hemoglobin and reticulocyte count, making hemolytic anemia less likely. Answer choice E, Rotor syndrome, is incorrect. Rotor syndrome also causes conjugated hyperbilirubinemia. However, the laboratory findings would show an increased direct or conjugated bilirubin. Key learning point. Gilbert syndrome is a common and benign intermittent jaundice seen in young adults that is triggered by stress, fasting, or illness. It is caused by a reduced activity of the enzyme UDP glucuronosol transferase, which is responsible for bilirubin conjugation. Liver function tests, hemoglobin, and reticulocyte count are normal. It is typically asymptomatic apart from the jaundice, and there is no need for further intervention. And that will conclude this episode of our USMLE Step 1 Questions podcast. I hope you enjoyed this episode and found the information useful. Please be sure to follow us at MedPrep2Go on LinkedIn, Facebook, YouTube, and Instagram to stay up to date with our content and what we're doing next. You can learn more and read other Step 1 questions at medprep2go.com. Happy studying!